This is Dr. Christina Arnold, and we'll be taking a step-by-step approach to an EMR specimen.
Step 1, identify the layers. The mucosa consists of epithelium, lamina propria, and muscularis mucosae. Neoplasms that extend into this layer are PT1A. The submucosa is underneath this black line. We know it's a submucosa because we see large caliber vessels marked by the asterisk. Lesions that extend down into the submucosa are PT1B, so knowing your layers is critical to approaching the EMR specimen. Beware of the duplicated muscularis mucosae. This tram track line highlights the original muscularis mucosae. As this layer becomes damaged through cycles of inflammation and repair, you'll notice you can acquire duplicated muscularis mucosae, or slips of muscle that are still within the mucosa. Lesions within this red line would still be considered PT1A mucosal lesions. Knowing when you're in the submucosa is important, and it's not always easy. Here are some tricks to knowing you're the submucosa. First, if you have a very clear muscularis mucosae, anything underneath that would be submucosa. Also, the submucosa has large caliber vessels and submucosal glands. Step 2, identify the margins. This YouTube link here is to show you how an EMR is actually performed. In a perfect world, your EMRs would be a perfect square, where the edges are your lateral margins and your deep margin is the deepest aspect of the specimen. But the world is not perfect, and in reality, the EMRs often come out like stepped on pieces of bubble gum and look something like this on the right. In these cases, your lateral margin is actually off to the side pretty deep, and your deep margin is here. So how I approach these cases is find where your submucosa is, and the area that binds that is going to be your deep margins. Your lateral margins will extend from your deep margin to the surface. Check out this video if you want to see how a real EMR is performed. All right, so let's identify the margins on a real-life example. First, I look for the large caliber vessels or glands, or vessels are highlighted by the asterisk. I know that's a submucosa, so the big muscle above this area is going to be my original muscularis mucosae. That means that this submucosa is going to be bound by the deep margin. The lateral margins will extend from the deep margin up to the surface. Step 3, now that you're oriented to the specimen and understand the layers and the margins, look carefully for Barrett's and dysplasia. This focus in the inset shows high-grade dysplasia in a patient with a known history of Barrett. Step 4, now back off the specimen and make sure and evaluate your margins. So we've identified our deep margin, our lateral margin, and our dysplasia is clear of these margins, which is good news for the patient. So putting this all together, the report will say high-grade dysplasia in Barrett esophagus, negative for invasion, all margins uninvolved. This stepwise approach is summarized here. Are you exhausted? I usually am when I look at the EMRs. So some good tidbits for you is these cases do take extra work, and you can bill them as an 88309. This is not the usual biopsy. If you need wordage for your billing committee, I'm just going to flash this up with some references, and this can help with your billing committee code. This is 88309. Another handy reference is showing how the lesions are followed and the likelihood risk of progression for your own reference. If you like this brief segment on EMRs, come to our short course at USCAP with Drs. Dorlam Hinland and Wendy Frankel, where we will teach all kinds of quick stepwise approaches to complicated lesions in the upper GI tract. Thank you.